dealing with pain, and we're going to talk about pain, but don't forget about trying to alleviate fear and stress, both in the cats and in the dogs. Because obviously if an animal is stressed or fearful, that can actually contribute to pain. Or the lack of sleep in hypervigilant animals that are very fearful. Hypervigilance and lack of sleep makes you painful. It's kind of like when you're in a human ICU and you never get to sleep, it escalates and makes your pain worse. So although we're really focusing on pain, don't forget to try and focus on the other things, fear and stress, in both dogs and cats. So when you're coming up with a plan to either prevent pain because you're doing an elective procedure or to treat pain because the animal comes in following trauma, it's really important to understand the whole pain pathway, why things get out of whack sometimes, and then where we can intervene. So very, very simplistically, what we have is every time we do surgery, we initiate a process called transduction. So we, with our scalpel blade, or it could be there's trauma, you know, the animal gets hit by a car or something. So immediately what we do is we disrupt nerve endings there, we cause inflammation. And inflammation will cause, you know, there's a release of all sorts of inflammatory mediators, and those mediators sensitize the nerve endings. And then what happens is that information from the site of trauma or surgery is going to be transmitted through the central nervous system to the spinal cord, and it arrives in a very specific part, into the dorsal horn of the spinal cord, where it is processed. And then when the animal is conscious, that becomes pain. Now remember, an animal under general anesthesia, by definition, cannot experience pain. Pain can only be experienced in the conscious state. But this and this is happening during surgery under general anesthesia, and we want to do something about it before they wake up and have that conscious sensation of pain. So there is some inbuilt modulating pathways. So animals do have endogenous opioids and so on, and there actually is a cannabinoid system which responds to cannabis, which they actually have. And all these things will help modulate pain. But what we're going to try and do is alter transduction, alter transmission, and build on modulating those incoming pain signals. Now what happens is if an animal is traumatized or has surgery without any benefit of analgesia, what happens is you have all of this transduction, which of course after the procedure's over, that surgical site is painful. That's what we call primary or peripheral sensitization, and we would expect that. And so we've got that process of transduction. But what happens is this becomes exaggerated, and we get more and more and more input and more transmission, more pain signals are now going to the central nervous system, and they bombard the central nervous system. And we used to think that once an animal was a few weeks of age and older, the central nervous system could not be altered. That is not true. The central nervous system is much more plastic than we think it is. And if you look at research animals that have experienced pain and look at their central nervous system, it is different. It gets rewired and altered by the bombardment with pain signals. So that is what happens, and that is what you've probably all heard of as central or secondary sensitization, or some of you, and that's why I've put this pictorial here, the animal becomes rewired. So now the actual processing of any future pain signals is altered. And because this is happening in the central nervous system, it's not just the surgical site that has altered pain sensation. When you go to touch an animal that has been painful for several days, it's not just the surgical site that's painful. The animal seems hypersensitive everywhere because you've altered its spinal cord. So this is what we want to prevent. We want to prevent this happening. And so we can intervene in many, many different places. This is what I'm saying. The actual preventing or treating pain, that's the easy part. You just have to know how to do it and then recognize the painful animals. So obviously, if inflammation is what starts it all off, then nonsteroidals are going to be excellent pain management tools. They work at the site of inflammation, but actually nonsteroidals have a very important role to play in the central nervous system as well. We could block the pain signal getting from here to the spinal cord with local anesthetics. We can enhance the modulating systems by giving the animal exogenous opioids, and obviously they work in the central nervous system, spinal cord, and in the brain. So we have lots of places that we can intervene. I think one of the very important key factors to understanding how long we need to treat is understanding how important inflammation is and how it drives pain. So often, people say, how long do I need to treat? Well, of course, the flip answer would be as long as they hurt, and then you can stop giving your analgesic, but we're not that good at assessing pain. So we need to kind of understand how long we can predict that pain might last. So what we have to understand is, post-operatively or post-trauma, just because the surgical procedure is over, the stimuli aren't over. The inflammation or the inflammatory injury continues. And that is what generates the nociceptive stimuli and this input and bombardment of the central nervous system. And depending on how much inflammation there is, it could last for as little as a few hours after, say, a very minor incision, or several days, or even several weeks, depending on how much inflammation and trauma there is. So this diagram, I've tried to to explain the why some pain protocols fail. So I'm going to go over this in a little bit of detail, because I think a lot of people suddenly go, I know now why, I gave my good pain management for the first day and then stopped, and the dog didn't look very good on the second day. So if we look at the very top here, and the time is arbitrary, but we could say it's several days. And what I've tried to pictorially show you is acute inflammation, which is quite significant at the start, right after surgery or trauma. And then if we do nothing, over time, inflammation resolves and goes away. But during the acute inflammation and this phase, which we call the time where we can reinitiate pain, can be significant. So the animal's painful here, and eventually the animal becomes more comfortable and pain disappears as inflammation disappears and abates. So what a lot of people do is they have an elective procedure, they give analgesics for a very short period of time, and so the animal feels very good here during the very acute inflammatory phase. You withdraw your pain management protocol, but there's still enough inflammation present in the wound that you can have complete reinitiation of the entire pain pathway, resensitization of the nerve endings, and so on. So the animal feels better here, but then is painful, just as in this one, from here until finally the inflammation resolves. So what we're really trying to do is provide our protocol, our pain management protocol, to go all the way through to this resolution phase where when we withdraw our pain management, nothing reinitiates, and the animal, you take it off its pain meds and it's comfortable and nothing reinitiates. Now, how long this line is going to be totally dependent on how much inflammation there is. So in a more pictorial sense, I would like to show you, so obviously here, you would all look at that wound and say, oh, definitely needs treatment because we've got a lot of inflammation. Some of you might think this looks pretty good and you might withdraw your treatment, but this is when everything reinitiates and you're back to square one. You cannot withdraw your treatment until you're in a phase where there's complete resolution and inflammation is almost negligible. Now, how long inflammation lasts after surgical procedures is not a thing that we understand completely, but it's obvious that the inflammation from this wound is not going to be as much as from a wound like that. That's kind of intuitive and makes sense, correct? But just to show you that inflammation is what drives pain, this is a study from humans, but the exact same study has been duplicated in the dog. This is looking at laparoscopy, so very, very little incisions, minor inflammation, minor trauma, versus laparotomy, big incision. And then what they did was they looked at an inflammatory mediator, which is easy to measure in blood, and obviously big incision, lots of inflammatory mediators, little incision, not much. And what they found was these were the people reporting their pain. The pain score completely mirrors the inflammatory response. So inflammation is what's important. So what, in a nutshell, does that all mean? What it really means is, yes, those small incisions really matter. So the smaller your incision, the more important it is. For a small incision is going to cause a lot less pain. Surgeons tell me that wounds heal from side to side, and I'm saying, well, pain goes from end to end. So once you kind of get those key concepts, I think the rest kind of all falls into place and is actually fairly easy. So we have opioids, non-steroidals, local anesthetics, ketamine, and a little bit about the alpha-2s, which I'll talk about in the next talk. But you know the pain pathway now, and you know now where these all work. So pain management, questions preemptive. Do I have to use lots of different drugs? Can I use long-acting drugs? Are there protocols without controlled drugs? And certainly I go to places where we cannot take controlled drugs, and I have to figure that out. And then some of the feral cat procedures. So opioids do tend to be the backbone of all acute pain management protocols. They're very, very, very effective, can be very inexpensive, but I know obviously you have to keep records. But there is very strong evidence that if you're going to use opioids, they need to be used preemptively. So preoperative administration has very positive benefits. It prevents central sensitization, and it actually, put it more simply, it requires a lower dose of an opioid to prevent pain than it does to treat pain once pain has occurred. So just to show you, this is like, good scientific, background for us, knowing that we need to get our opioids on ahead of time. So this is meperidine, very, very short-acting opioid given to animals before spay, post-operatively, or some animals didn't get it at all. But we know that analgesic, that opioid, probably only lasts an hour, hour and a half. But by giving it pre-operatively, even out as far as 8 hours, 12 hours, and 20 hours, the dogs that get it pre-operatively have an obvious benefit to that drug because it prevented central sensitization. Other advantages of using opioids prior to induction are it reduces your anesthetic requirements for your induction agent and your maintenance agent. So they're less propofol, if that's what you're using, less isoflurane. You get fewer cardiovascular responses to surgery. You have better maintained blood pressure because you're using less induction and maintenance agent, and you actually end up with less respiratory depression. Although some people think that's counterintuitive because we're talking about opioids. But because you use less of the induction and maintenance agents, that is true. Does the route of administration matter? Absolutely yes. And we have done very good studies in cats, and they've been done in dogs as well. The one inefficient, almost like very poor subcutaneous administration of opioids is the worst or least effective method of giving opioids to dogs. You get slow onset, you get more nausea, you get more vomiting, you have less intense effect. So try, if you have an IV catheter, use that, and if not, IM is your second best choice. Sub-Q, extremely ineffective route of administration. And people think if you give it sub-Q, it lasts longer. We have disproved that. That is not true. Sustained release buprenorphine is something I'm getting a lot of questions about, and actually Dr. Levy was asking me about it. And it is something that can be bought from Zoo Farm, sell it. There's not a lot of good data, but there is a nice paper came out of Colorado State just recently using it in a feline OHE model. They gave one single dose of this sub-Q, and then they compared it to giving the oral transmucosal buprenorphine, just dropping it in the cat's mouths. And both protocols were equal. There was no difference between treatments. All the cats did quite well. So certainly these sustained release formulations are attractive for feral cats. The only thing I would alert you to is I'm getting quite a lot of phone calls, and if you look at the Colorado paper, injection site reactions are being reported with this. And we, obviously an injection site reaction in a cat is a little bit worrisome. Non-steroidals for dogs, definitely if inflammation is what drives pain, we should be using non-steroidals. In dogs, it's easy, right? You got tons to choose from. So that's easy. In the cat, not so easy. But just to point out that we have 2 licensed non-steroidals for cats in the United States right now. We have meloxicam injection. It's a single use only, sub-Q for surgical pain. And we now have Robenacoxib, which is, its trade name is Oncior. So when I say we have it, it is approved by the FDA. It was approved this March for use in cats in the United States. It's got a 3-day label for orthopedic surgery, ovarian hysterectomy, and castration. You can find out a lot about this drug at the FDA website. It's going to be oral only in the United States. It's an oral tablet. The Feline Advisory Bureau gave it an award for palatability and easy to give. So we're not sure when we're going to get it, but it should be early next year. And it'll allow you on label to treat cats with a non-steroidal for 3 days. Local anesthesia, I think, underutilized, and can be very, very effective. These are just images of us down in the Yucatan doing a spay and neuter clinic, obviously on picnic tables here. So we were doing local line blocks in the dogs, in the female dogs, and we were doing injections in the dogs, in the male dogs as well, prior to surgery. So local anesthetics, there is good data to say that they do help. In this feline spay study that was published back in 2008, infiltrating the skin, mesovarium, and the muscle layers, they were able to give fewer top-ups, have to alter the level of anesthesia less. They had lower heart rates, less respiratory depression. So local anesthetics beneficial in cats. And here is just, if you go to this website, the VASG website, you can learn how to do an intratesticular block in a male cat. And that's what we did when we were down in Mexico as well. Intraperitoneal local anesthesia for canine spay has been well documented that it's very beneficial. There was a publication came out of Michigan State University a long time ago now, 2003. All the dogs received butorphanol, and then they either got lidocaine intraperitoneal, bupivacaine intraperitoneally, or saline intraperitoneally. And then if they got lidocaine in the peritoneum, they also got a splash block of lidocaine in their incision at closure. So what was the results of that? What they found was bupivacaine in the peritoneum and on the wound. These dogs had lower pain scores and required less rescue analgesia. And then these are just the exact doses and protocol that they used. And then the wound infiltrated. So inexpensive and easy to do, and it's not a controlled substance. What about ketamine? Ketamine is known to prevent central sensitization, but when you use it as part of your anesthetic protocol, is it of any benefit? Well, the answer is yes, it is. Certainly for dogs, we know that. This was a study done in the United Kingdom where the dogs had no other analgesic, none of these are analgesics, but they got ketamine, they either got saline at induction and extubation, ketamine at induction followed by saline, or saline at induction and ketamine as they woke up. And that was the dose they got. So what did ketamine do for spay pain? Well, what they actually showed was that when they were assessing pain, good evaluators, look at this, big difference between the pain score in the dogs that got ketamine prior to their spay incision. And no other analgesics on board, and it made a difference. What else did ketamine do? They looked at wound sensitivity, and it made a huge difference. The animals that received ketamine, and it didn't really matter so much whether it was before or after the spay, but as long as they got it, it took a lot more pressure on their wound to elicit a response compared to the dogs that got no ketamine. So using ketamine as part of your protocol is a beneficial thing to do. And then to finish up on multimodal, do I have to give lots more than one drug? Well, intuitively it makes sense, but there actually aren't very many good studies. But there are a couple of studies combining non-steroidals and opioids that show that that's a good combination. One of them is in cats, and they looked at combining buprenorphine and carprofen. This was done in the UK, where both of those are licensed for use in cats, single treatment only. Now, what they found was there was no difference in how sedate the cats were, so that probably wasn't a factor that altered how they were able to score the cats. But what they found was if you combined an opioid and a non-steroidal, this is the purple line here, much superior. The opioid alone, very good up until when you'd expect it to wear off. And then the non-steroidal alone, good overall, long-term, but not as good as the combination. So it is a good combination. And then this is a study that was done here at University of Florida, actually with our in conjunction with our shelter group. And we looked again at buprenorphine and carprofen, and we found it was very beneficial combination. We found that if you include your buprenorphine ahead of the surgery, you need a lot less propofol to induce them. Those dogs, because they had less propofol and probably less inhalant, better blood pressure. The combination, we got longer lasting analgesia, and we actually measured the spay incisions and photographed them. And if you include the non-steroidal, we had less, and we could document less wound swelling as well. Remote area spay and neuter initiative, something that everybody involved in shelter medicine is probably going to volunteer to do. And I've been going down to the Yucatan and doing dog and cat neuters and so on, very educational thing for the kids down there and for our students. And often we go down there and we can't use controlled drugs. We just can't either buy them, and we, God forbid, trying to take controlled drugs through a Mexican airport. So I decided I wasn't going to try it. So I started looking around for some protocols that I thought I could use that wouldn't involve controlled anesthetic, and I came across this paper, and they looked at using propofol or ketamine following medetomidine. And what they found was that an alpha-2 followed by propofol is very, very effective for doing routine procedures in dogs, and this is what we did. We sedated our dogs. Well, now if we go, it'll be dexmedetomidine. We did our local block, and then we used IV propofol as needed. And here's Dr. Azaza working on one of our dogs down there. These dogs woke up very, very nicely. They had to usually walk home. They didn't, get picked up and taken home. They had to walk home after their procedure. And then just finally, whether or not I can tell you that we have great updates on analgesia for our feral cat population, we've been doing and trying to develop better techniques for the feral cats, trying to get faster recoveries and hopefully better analgesia. It's very difficult, as you can understand from what we've talked about, to assess pain in some of these feral cats. I would say that predominantly this is still our backbone, the TKX. This paper is available now online. It's just being published. And we had faster recoveries with this newer protocol, but we did have a lot of animals that were having very, very low saturations on the pulse oximeter, and whether or not that's a long-term issue or not. But certainly we're developing or trying to do better with the feral cat protocols. Certainly it's something we're quite motivated to improve on. So hopefully that just reassures you that once you can recognize pain, the treating it and preventing it part is pretty easy, and it's not as complicated as some people would try and make out nowadays. So thank you.